Pharmacological interventions. At the conclusion of this learning module, the participant should be able to 1. Relate various pharmacological options available for management of neonatal abstinence syndrome, and 2. Explain why the various clinical protocols to address opioid withdrawal in clinical scenarios and convey why it is important that providers are consistent in following established protocols. These graphs show the differences in length of stay based on the substance. Babies prenatally exposed to buprenorphine may have a shorter length of stay and morphine requirements than a baby prenatally exposed to methadone. Comparison of morphine dose, duration, and hospital length of stay with maternal use of methadone versus maternal use of buprenorphine in pregnancy is shown here. Not only is the substance important, but other factors can have an effect. A large variable in the amount of morphine required of the neonate is the amount of cigarettes that the mom smokes. In a recent study of moms in a medication-assisted treatment program, moms reported cigarette use during pregnancy of below average was 5.8 cigarettes per day, average was 1.3 per day, and above average was 21 cigarettes per day. There was a direct correlation with the amount of maternal cigarette consumption and the amount of morphine the baby needed, as well as increase in the length of baby stay in the hospital. There also may be a correlation with nicotine consumption using electronic cigarettes, as the amount of nicotine varies in each cartridge of the e-cigarette. Studies need to be done in this area.
Trends in pharmacologic treatment for neonatal abstinence are reflected in the chart on this slide. Morphine is the initial drug of choice in over 75% of nurseries. Methadone for NAS treatment is on the decline, as is phenobarbital. Clonidine use as an adjunct is on the rise. So now that we have an overview, let's discuss when pharmacotherapy is initiated. Initiation of pharmacotherapy is triggered when the modified Finnegan score is 12 or above twice within 2 hours, or an average of 8 over 3 score periods 2 hours apart. Once initiated, it is important to dose consistently. One must choose to dose either every 3 or every 4 hours with feedings. It is easy to titrate dose based on scores, since morphine has a short half-life. The oral dose is usually 0.03 to 0.1 milligrams per kilogram dose every 3 or 4 hours. The maximum oral dose is 0.2 milligrams per kilogram dose. It is very important to remember that if a newborn required IV administration of morphine, the equivalent oral dose is 3 times that of IV. Consulting a pharmacist is advisable if IV morphine is required.
Morphine is initiated and the dose titrated based upon the Finnegan Neonatal Abstinence Scoring Tool. When the score reaches less than 8, then maintain the dose for 72 hours. At that time, consider beginning to wean the morphine. The dose should be weaned at the same time each day to obtain a steady drug serum level. The dose is weaned by 10% of the maintenance dose each 24 to 48 hours.
Methadone is used by fewer NICU centers than morphine for neonatal abstinence syndrome. Due to its long half-life, it is difficult to increase or decrease doses as necessary. It also may take 3 or more days to reach plasma levels that will ameliorate the NAS symptoms. Instead of dosing every 3 to 4 hours as with morphine, methadone is dosed every 6 hours. Since the half-life of methadone is 16 to 25 hours, the wean time may also be longer, necessitating a longer length of stay compared to morphine.
Phenobarbital has been used in addition to morphine as an adjunct for NAS. It may be initiated if the morphine dose gets to maximum level and the FNAS scores continue to be elevated. Phenobarbital is not effective to treat diarrhea of NAS. Morphine is the drug of choice to reduce peristaltic action that results in diarrhea. Once a baby is weaned off morphine, he may go home on phenobarbital. Phenobarbital is reduced based on blood levels. Clonidine is not FDA approved for use in newborns. However, it has been found to benefit newborns when weaning of morphine has failed. It stimulates presynaptic adrenergic receptors, thus reducing norepinephrine, which is a causative agent for many NAS symptoms. The dose is 1 microgram per kilogram per day. It has a long half-life of 44 to 72 hours. No sedation is associated with clonidine. The drug is antihypertensive. When the drug is initiated, blood pressure must be assessed for hypotension. Once discontinued, blood pressures must be assessed for rebound hypertension.
Sol buprenorphine has been used in 2 investigational studies with small sample sizes of newborns. The drawback of the drug is that it is administered sublingually to newborns, which may be a clinical challenge. It is dosed every 8 hours and has been shown to reduce length of stay compared to use of morphine for neonatal abstinence syndrome.
Research has found that consistency in pharmacologic treatment among providers, especially in weaning the newborn of morphine, will result in a shortened length of stay. Coupled with that is the need to assure competency and reliability among nursing staff who are assessing the newborn with the Finnegan Neonatal Abstinence Scoring Tool, or FNAST.
Providers who are prescribing the morphine doses must get the most accurate assessment for appropriate prescribing and weaning decisions. Research has also shown that when nurses are reliable and competent with the use of the FNAST, there is a reduced length of stay by 3 days.